So we're going to talk about repetitive behavior in autism. And just as a declaration of conflicts of interest, so I have received grant funding from the Ontario Brain Institute, Brain Canada, and Hoffman LaRoche Limited, but none of those will really have any impact or effect on this particular talk. And so the conclusion of this presentation, participants will be able to, well, the objectives are noted here. I don't need to read them out. And we could talk at some point about objective number 3, if people want to. So this is sort of what I want to cover today. So conceptualizations of ritualistic behavior in autism, case descriptions, and then sort of talking about diagnostic possibilities and how we might explain some of the symptoms I've seen in these patients. And then we'll have time for discussion afterwards. Okay, so, the very first description of autism, at least in English, was by Leo Kanner in 1943. Hans Asperger wrote shortly after that in German, I believe, and there was a woman in Russia, I can't think of her name right now, unfortunately, who had written sort of earlier in the 20th century. But all three people had talked about ritualistic behavior and repetitive behavior as being important in autism. And there's been, I think, less research about it than I would have expected at this point. But what Kanner said was that that he talked about this anxiously obsessive desire for the maintenance of sameness. So he felt that the ritualistic part was that things had to be exactly the way they were done the very first time. And if that wasn't done, then people would become very upset, and there'd be agitation and acting out kinds of behavior. So moving ahead, so autism was first formally described in DSM-3 in 1980. It was called infantile autism at the time. And although in many ways the diagnosis was quite narrow relative to what we have now, it was also much more vague than it is now. That it was, pervasive lack of responsiveness to other people, gross deficits in language development. So those are really vague kind of statements, and bizarre responses to various aspects of the environment is also a very vague and really open to interpretation statement. But you can see that even there, one of the criteria was a sort of resistance to change. So in DSM-3R in 1988, they introduced this sort of buffet menu approach where you have to have a little bit from column A and a little bit from column B and a bit from column C. And we can see in the third area, in the C criteria, they talk about markedly restricted repertoire of activities and interests. And what two of the criteria were marked distress over changes in trivial aspects of the environment, but also unreasonable insistence on following routines in precise detail. And I think what some of these descriptions leave out is it should be insistence on following routines that most people wouldn't think of as being important, because we all have routines that need to be followed, and oftentimes they're quite important. But really with people with autism, I think what's more unusual is when they are things that don't seem important, and yet people are really insistent upon following those routines. And so in 1994, when DSM-4 came out, it was now called autistic disorder. Again, same approach. They talk about apparently inflexible adherence to specific non-functional routines or rituals. So we can see that with each iteration of the DSM, the description has changed somewhat. And so it's not clear we're actually talking about the exact same kinds of behaviors, unfortunately, with each change in the DSM. So most recently, when DSM-5 came out in 2013, and it's now called autism spectrum disorder, the description is similar. There are perhaps more examples, but it's just the insistence on sameness, inflexible adherence to routines, and inflexible adherence to ritualized patterns of behavior. And here they also point out that it can either be verbal behavior or non-verbal behavior. So with the DSM, as time has gone on, there has been some changes in the description, and it has perhaps become more, perhaps better operationally defined in terms of being able to somewhat objectively understand what's being talked about. But as I said earlier, I think there's much less research in this area than I would have expected. And so certainly what often happens is that, questions about OCD come up. And what I try to do with people when we're talking about these kinds of behaviors, first of all, people will sometimes use the word compulsions or obsessions. And I think it's important not to use that unless we're sure they're correct. Obsessions are thoughts, urges, or impulses that create anxiety, and then compulsions are behaviors designed to neutralize that anxiety. And although some of these behaviors certainly look like they may be related to OCD, we really don't know for sure unless people can describe them for us. So for people with lower cognitive abilities or people who have are minimally verbal or nonverbal, that they aren't necessarily able to describe why they're doing these things. And so we don't know for sure that they're driven by anxiety or thoughts. And in fact, the medications that we use for treating these kind of behaviors, typically with OCD, so SSRIs, are not necessarily very effective in treating ritualistic behavior in autism. And in fact, a Cochrane review a few years ago suggested there was no evidence really to support their use in the treatment of repetitive behaviors or the ritualistic behavior in autism. And in fact, it suggested there may be more harm done by using SSRIs in some patients than benefit for those people. And certainly that has been my experience with some patients with this sort of need for things to be exactly right. So there was a boy I used to see who in his Venetian blinds at school or at home, they had to be just exactly parallel and sort of at the right angle. And if they weren't, or if anybody moved them, he became very aggressive and very agitated. And against my own better judgment, I started him on an SSRI, and it made his behavior far worse. The aggression got significantly worse. And I've seen that with a few other people. So it might be obsessive compulsive disorder, but it might not in these cases. But certainly there are some people with autism spectrum disorder who have pretty classical OCD. I've had a few patients who had the whole germs and hand washing kinds of symptoms. But in the sort of ritualistic stuff that we're talking about, I'm not sure that it actually is related to OCD personally. Okay, so now what I want to do is talk about the symptoms that we are talking about. The cases. So I'll talk about a couple of cases, and then I'll just mention one person, another person who bears a striking resemblance to these. The first two I'm going to talk about. And the reason I had wanted to talk about these and thought it was interesting is because it's three people that I've seen within the last year who've all had very similar descriptions of their behavior from their parents. And it's something that I cannot think I've seen, I don't think I've seen very often, if at all, previously. So first person, we'll call him Bart. Bart, when I saw him first, was recently was 11 years old. He lives with his parents and his two younger sisters, and he is in grade 6 at school. So he was referred by his pediatrician for assessment and treatment of what the pediatrician referred to as significant behavioral changes. He seems to be starting and stopping movements. So I had actually seen him previously when he was much younger around behavioral issues, which we'll come back to, but I hadn't seen him for several years. So just going back to his earlier history, he was diagnosed with autism spectrum disorder at the age of 3. He was involved in an early intensive behavioral intervention program and made some gains, although not as much as his parents would have hoped for. What was also quite interesting about his sort of past, especially if you look longitudinally, was he would have several periods of time where he would lose skills, particularly language was the one that was most noted for some period of time, and it would then improve again, but never with each sort of these periods and this loss of skills, he would never get back to where he was prior to that particular episode. So it's sort of like a somewhat downward course in terms of his language, with sort of ups and downs, but the downward trend overall. And he had, I don't know why there's twice there. So he was seen by a neurologist in relationship to this. They couldn't find any explanation for it. I think he had some immunological workups done that they didn't reveal any abnormalities, and an MRI scan at the time didn't reveal any abnormalities. And what his parents had said at the time was it wasn't just them thinking about this, that in fact the speech and language pathologist they were working with privately had also noticed it over this sort of gradual loss of skills over time in the area of language. So he also had a history of significant agitation and aggression, and that's why he had originally seen me. He had aggression and self-injurious behavior, usually with things not going as he expected or wanted. And this was both at home and at school. He was also involved with behavior therapists, and he was started on risperidone up to a dose of 2 milligrams daily with a significant improvement. His parents reported that both at home and at school, the aggression and the self-injurious behavior had been essentially eliminated at that point in time. And there weren't a lot of adverse effects. He didn't gain very much weight or anything with them. And sort of shortly after that is when I lost touch with him until recently. So early in 2021, he stopped eating. And what his parents noted was that it sort of happened gradually. Initially, he stopped chewing his food and then would swallow it and then stopped eating entirely. And he also began to have enuresis, which hadn't been a problem since he was an infant. And with the weight loss, what his parents noted was that he would sit down appropriately for dinner and looked like he wanted to eat, but just wouldn't. And his parents began to feed him, but they also noticed that as time went on early this year, that with almost any activity he was involved with, he would freeze, was the word they used to describe it. So he would freeze as he was doing it, and he wouldn't move on until he was given a prompt to do so, or until he was told it was okay to do so by his parents. So as time went on, he began to feed himself again, but what would happen is he would sit down at the table and he wouldn't do anything until his parents said, pick up your spoon. And then he would pick up the spoon, and then he wouldn't do anything. They would have to say, put it in your bowl. And sort of literally with each step of eating, they would have to tell him what to do. And so it took an inordinately large amount of time. And this was somebody who previously had fed himself without any difficulties. In talking to the mom recently, because we were trying to talk about, is this that he couldn't do these things or he wouldn't do them? And she said that he actually looked quite frightened at times when he sat down to eat and things. There were no episodes of choking, so there's nothing that had happened clearly that had led to this. But his parents also said this kind of freezing occurred with almost every single activity that he was involved with. And it happened at school up until schools closed in April. And so walking somewhere, they would need to tell him to take a step if he was sitting down, feeding himself, and even things like flushing the toilet. They would have to tell him to flush the toilet after he stood up from the toilet. And his parents were pretty clear that if they had not told him to do something, he would have just stood there and not done it until somebody prompted him or told him what to do. And so this was something that had never happened to him previously. This was completely different from any other event he had ever had, and was quite impairing for them because they said they really couldn't do anything or go anywhere because it would take so long. And he had lost quite a bit of weight initially with not eating. So in terms of his past medical history, he was healthy other than these periods of loss of skills. Genetic testing revealed a de novo 3q29 duplication, which was a variant of uncertain significance. He had never had any operations, no hospitalizations. He's never had a seizure. He does have a severe nut allergy and carries an EpiPen with him. In the past, he was on numerous supplements and antifungal agents, as well as chronic antibiotics for the treatment of what was thought to be, or at least hypothesized to be, some kind of autoimmune process related to group A beta hemolytic streptococcus. So in terms of his family history, there was no consanguinity. His mother had never had any miscarriages. He had 2 younger sisters, I mentioned. With one of them, there was no history of developmental problems or psychiatric difficulties. The younger sister had an early language delay, and people had noted that she used her soother well beyond what one might have expected for a child. Additionally, one of the mom's 2 sisters had a history of significant social difficulties that she found it really difficult to develop and maintain close relationships with people, and had a number of partners for short periods of time before ending those relationships. But there was no other history of any developmental or mental health problems, and there was no family history of autism either. His social history was pretty unremarkable. His pregnancy, his mother said, was fine, that there were no infections. She didn't use any medications. There were no substances. So Bart was born at 39 weeks gestation by spontaneous vaginal delivery. He gained weight well during his first year. He walked at about 1 year of age, but by the age of 2, he didn't have any single words, and he didn't have any phrases by the age of 3. So when I saw him this year, and I saw him in person initially at Victoria Hospital, so we were able to get his height and weight, which are pretty average, and but I couldn't get his head circumference. His heart rate and blood pressure were fine. He had no dysmorphic features. There were no tics and no abnormal involuntary movements. He has always walked on his toes. And in fact, an MRI done in the last couple of years revealed some possible degeneration in one of his thoracic vertebrae. And his mom said somebody had speculated that maybe related to walking on his toes or being hunched over, but they're not clear about that. When his name was called, he would sort of respond occasionally, but he didn't initiate any interactions with myself or with his mother. He sat beside his mom and occasionally wandered around the room, but really didn't walk very far. And when his mom would ask him questions, or when I asked him, typically he didn't respond at all, but he did have occasional word approximation if he was prompted by his mom. At one point, his mom pulled some food out. It was like applesauce in one of those small plastic containers. And he took the spoon, but it needed prompting exactly as I described it earlier from his mom at each step, that he would sort of look at her expectingly almost, but wouldn't do anything unless his mom told him exactly what to do. So before we move on, are there any questions or comments or thoughts about this with this boy? So what's unusual to me, and we'll describe it with the next person also, is that I can't recall anybody that I've seen in the past, and maybe I didn't pay attention or something, but who needed that sort of constant prompting to do anything. And this was a completely new behavior for him that hadn't been seen previously. So Dr. Goldberg wondered about the genetic abnormality being associated with any known syndrome. And the answer to that is no. It's so the geneticists refer to it as a variant of unknown significance or uncertain significance. So it's not, there's no clear syndrome associated with it, and there's no clear, it's not known at this point in time. And so Monique Nagtigal was wondering, was it happening with parents or with others as well? So this happened both at home and at school. But it started early this year, and then school closed in early April. He was in elementary school, he was not in a developmental class, and so he was in a regular class in the public system. And so when schools closed in early April, or after, I guess mid-April maybe, that he was home after that. But prior to that, this kind of behavior had been happening at school, and his teachers and his educational assistants had commented upon it as well. Any other thoughts or comments about this boy, young man? Okay, so actually somebody has raised their hand. Let me see if I can find that. Mary Jane Venus. If you could just unmute yourself, Mary Jane. There you are. Hello.
Yes, just was wondering, is this a child that would model behavior? So if the parents asked him to do, like at the dinner table, do the same as mommy and then model eating, would he follow that?
I don't know that his parents did any of that, to be honest, Mary Jane. I think that, first of all, in the middle of the pandemic, I think there was a lot of things going on, and I think they were really frantic about what was happening and the fact that he had lost quite a bit of weight. And I think they were more concerned initially, anyway, with just getting him to put some weight back on it. And
Right.
we're really concerned about what was going on because it was such a different kind of behavior. I don't know in the past that they would have tried that. That's a good question. I don't know the answer to it.
Okay, thanks.
Why do you ask? What are you thinking about?
I just thought that it might have helped him to, I don't know, get past the behavior, or perhaps, reduce the number of prompts they would have had to have been giving him if he was eating the same as they were eating or something. No.
Yeah, no, I don't think they tried that.
Yeah.
Dr. Kelly, all the way from Kingston. How are you, first of all? And also, if you want to unmute yourself.
I'm good. Nice to see you. Anyway, I was wondering if there were any other signs of anxiety or depression.
So no, and when I saw him, and I've seen him a few times now since late in the spring or early summer, He always has a smile on his face. Even in the middle of all this, he always smiled and didn't look perturbed. His mom did say though, because I was talking to her recently about, what she thinks caused this to start, and the only explanation she had was that he looked quite frightened. So she wondered, I guess, about anxiety, but that was more. I don't know if that was more to do with food, and there was no obvious precipitant that there wasn't anything obvious that he should have been scared of. So there was no other long-term evidence of anxiety.
Thanks.
Question from an anonymous attendee: is the level of cognitive functioning known? Yeah, he's intellectually quite impaired. I don't know the exact results of his cognitive testing, but he has a significant intellectual disability, sort of towards the lower end of moderately disabled, or perhaps at the upper end of severely disabled. And Dr. Ogilvy asked, did it predate COVID pandemic or start at the same time? And so and did it happen with drinking? So this started early in 2021, so after the onset of the pandemic, and that's something I've wondered about with him and the other couple of people I'm going to talk about. And I believe it also happened with drinking. So it wasn't just with eating. It was actually with every single thing he did, according to his mom, even using the toilet, walking out the door, stuff like that. And Professor Dr. Martinez asked about was the freezing when the child when he was under stress or triggered at normal times, and it wasn't really any particular stress most of the time. It was just eating dinner or things like that. That the question in my mind was, was this related to something to do with the pandemic and changes in his life? And so there weren't any acute stressors that can be pointed to in the moment. That could be pointed to in the moment, but that's I certainly had wondered about that, but there was nothing that his parents could point to. And then, so if people can do me a small favor and either use the Q&A, and let's say everybody will use the Q&A, otherwise I have to sort of go back and forth, which I realize that's a first world problem, but nonetheless it makes it easier for me. So Claire had wondered about selective mutism, and so he is essentially nonverbal to begin with, though. And I remember having a lengthy discussion with Jeff St. Pierre once about whether people who are nonverbal, I think Jennifer McLean and I had talked about it, whether people who are nonverbal could have selective mutism or not. But he wasn't necessarily making any less verbal or vocal noises than he had in the past. And the only words he has are really prompted, and they are, when I said word approximation, they are gross approximation. I mean, I wouldn't have recognized them as words. That was only when his mom sort of interpreted for me that I could understand them. Okay, so moving along. He has autism spectrum disorder, he has an intellectual disability, he has a duplication on chromosome 3, as I mentioned. And then, I don't know how to explain this, and we're going to come back to that later on. We'll talk about what possible other diagnoses are. I mean, right now, does anybody have any thoughts? Elizabeth Kelly had wondered about anxiety, and certainly that's something I had wondered about also. Are there any other thoughts that people had as to sort of how we would explain this diagnostically? Okay, so that is crickets and tumbleweeds. So so what happened to our friend Bart? Well, he was investigated by neurology early on. He was seen by a neurologist. He had an MRI scan. It didn't show any abnormalities. He had blood work done, including C-reactive protein, which was not elevated, which suggests there was no acute inflammation anyway. And neurologists basically said they can't find any reason why this has happened to him. Further genetic testing was done. I think he might have had the autism panel done, and I don't think it showed anything further. And he was seen by a developmental pediatrician at Victoria Hospital who couldn't find any other evidence of biological problems. So there's no clear medical explanation for why this has started at this point in time. His pediatrician had started him on lorazepam. So she wondered about whether or not it was catatonia associated with autism. And it started him on lorazepam, as that's one of the treatments for catatonia. And she had gradually increased the dose up to 6 milligrams a day, and there's minimal change. And saying minimal change is overestimating how much improvement there was. So at the beginning of the summer, after we had weaned him off of the lorazepam, I started him on the fluoxetine, wondering about anxiety or thinking about anxiety, and perhaps there was some fear, or was it some kind of ritual that he had now developed for whatever reason where he couldn't do anything unless he was prompted, and if he wasn't, that there was some anxiety about doing it. And so we started him on fluoxetine. It took us a while to increase the dose to 20 milligrams as we used the liquid. And having seen his mom and this boy recently, his mom said that he seemed more independent. He was doing more things without prompting, but still needed significant prompting throughout the day, both at home and at school, but it was certainly less. He was eating, I think, more independently now, and his mom was saying he was flushing the toilet without prompting, and she recognized that that's a very low bar, perhaps, but nonetheless, she said it was a significant improvement and was moving in the right direction. And they also reported at home and at school that he seemed happier. So with the fluoxetine, well, after starting the fluoxetine, things seemed to improve. What his mom and I talked about in the last couple of weeks, though, was we don't know whether the fluoxetine just happened to be coincidental to that improvement, or whether or not it was sort of causally related to the improvement. And what we agreed, because his mom was asking about Prozac, whether we should continue it, and I suggested that at least for now, given how hard this year's been for everybody, but particularly for Bart, that it would make sense to leave it for now, perhaps until the world goes back to normal, if that ever happens. Mostly because if we stop the fluoxetine, if it's not helping him, then that's fine. But if it is helping him, we really want to take that risk and go backwards potentially with him. And also, he's not having any side effects with it, so it's not as though there's a problem that it's causing right now, other than if he doesn't need it, he shouldn't be taking it. So that's where he's at as of a week or two ago. I mean, so let me just stop there and ask again if people have any thoughts about that his pediatrician wondering about catatonia, if people have thoughts about that, or if people would have done things differently. And certainly I would have liked to have included a behavioral specialist. I just think because this happened and I didn't see him until May, and the and waiting list for things, there really wasn't an opportunity for that, unfortunately. Okay, Mary Jane, these are any of the cases entering puberty? So this person is, the next person is not. And so the question that Mary Jane had was, could changes in hormones increase anxiety? Could changes in hormones cause an increase in anxiety and would trigger these behaviors? I suppose anything's possible, but the fact that that I cannot recall ever seeing somebody with this level of need, and the fact that he would almost do nothing without being prompted, and not just being prompted, but at each and every step, I think if it was related to hormonal fluctuations and puberty, that I would have seen it, or we would have seen it previously, and I can't recall ever talking to anybody about a patient like this either. So I mean, I suppose it's possible. I don't think that's the explanation, though. And there was one other question, and then I'll come back to you, Claire. So Beth, Elizabeth Kelly had said, the reason she asked about depression is the old literature on loss of skills. And all I can really say is that it's, his sleep was not changed. He didn't appear sad, according to his parents. He didn't, he wasn't crying. It's difficult to comment upon his attention and his energy and stuff like that, because he wasn't doing anything without needing problems. His parents felt that wasn't the explanation, though, and they said that he didn't look sad to them. He looked more scared. But it could be, and that if that was the case, I suppose that might relate to why things might have gotten better with the fluoxetine also. Dr. Mitchell, I will allow you to talk. If you could just unmute yourself.
Okay. Yeah, so I don't think I would have managed this case any differently. And it's certainly difficult to sort some of these things out during COVID. The reason I suggested selective mutism is because in some of the patients, and typically they're of normal intelligence, that I've had with selective mutism, they behave in this way, that things are okay, and then they will suddenly be completely unable to do anything, not just talk, but even move sometimes, to the point that people raise the question of seizures. So anyway, that it just had a bit of a flavor of that. But he also reminds me of another patient that I think you saw as well, who had autism, was a teenager, and suddenly developed these behavioral arrests. So he would stop and just not do anything. As I followed him a little bit and observed it, he did start to seem to be muttering something under his breath at the time. He also had some hypopigmented spots, so we started working him up for tuberous sclerosis. And that actually took a while, took a couple years. And my thought over time was that he was really perseverating, was kind of stuck, perhaps obsessing during these behavioral arrests. And times where he just wouldn't do anything. So I did prescribe sertraline, and then they came back about a year later, and mom said, everything is great. It's all better. He's back to the way he was, which was still had plenty of symptoms of autism. And I said, oh, great. So you took the sertraline? And she said, no, it just resolved on its own. So that was a great lesson in causality, because if he'd taken the sertraline, I would have concluded that that had treated him. But it just was definitely there for 2 or 3 years in adolescence and then resolved. So I don't know if that helps this case, but they seem similar.
Absolutely, and I think that what this young man's mother and I talked about, I don't want to say extensively, but at fairly great length, I think she would prefer he not take any medicine, as I would assume most of us would. But it's the question is timing. When do we stop it without running the risk of things going backwards? And I think what makes it so difficult is that this person is essentially nonverbal, and so really can't tell us anything about what's going on. I think that's what makes it so challenging.
Absolutely.
And so Dr. Ogilvie had wondered, can we call it an adjustment reaction or stress reaction in a child who would have trouble processing or verbalizing stress? So Jackie, I'm gonna table that. I think that's the phrase, and I come back to it in a moment, because that's certainly something that I've wondered about, with having seen now 3 people with the exact same problems in the past year, and never having seen them before. Okay, so let us move on then to second person, and we will call him Stuart. And so Stewie is a 9-year-old male, lives with his parents and his 2 older siblings. He is in grade 5, so he was born late in the year. He was referred by his pediatrician due to repetitive behaviors. So he was diagnosed with autism at the age of 3. He wasn't felt eligible for early intensive behavioral intervention, as the providers felt that he wasn't, that the severity of his cognitive impairments and his autism made him a poor candidate, because they felt he wouldn't get benefit from it. He has a long history of preoccupations, including the eyes and elbows of other people. So he would walk around touching people's elbows, which created a fair amount of problems out in the community, as one can imagine. And he had a fair number of motor stereotypies, sort of classic looking at his fingers. He would also line up his toys, and he would sort of flip through books, so those kind of sensory sorts of things. He had a history of significant aggression and self-injurious behavior. So he's been on risperidone, aripiprazole, and olanzapine. On olanzapine, there was a fairly significant improvement, at least initially, in the aggression and self-injurious behavior, but he had gained a lot of weight, and that was a concern for his parents. He's also extremely hyperactive and impulsive. I went for a walk when he was, this was several years ago, and he was quite agitated. And so we went outside for a walk, and as soon as the door opened, he basically took off. And so we had to sort of chase him down, because he was running towards Sanatorium Road, and his mom said that wasn't particularly unusual, that they basically had to hold his hand constantly. So we tried him on lisdexamphetamine, and with Vyvanse, the agitation and the aggression increased quite dramatically, and so it was discontinued. We later started him on guanfacine, and this helped somewhat with impulse control and overactivity, but they remain problematic. So in the fall of last year, he began to have problems completing any activity at home and at school. And it was seen in many activities, but particularly anything that there was a routine or a specific way that things had to be done, he would then have these episodes where he would just not complete things. And when his mother was describing it, I was actually sort of dumbfounded at the description that she gave, because it's almost exactly identical to the boy we just discussed. So sometimes he would point to what he wanted to do or where he should be going, but wouldn't actually go there unless someone said it's okay. And it's not as though somebody's saying it's okay or that's fine was enough, that he would basically, so his mom described one day that out in the backyard, they have a trampoline. And so he would go and stand at the door, but wouldn't do anything unless his mom said, okay, you can go outside. And then he would take one step, and then she would say, okay, now you can go to the trampoline. And basically, so with almost literally each step that he took, he needed somebody to prompt him or give him permission, is the way his parents described it, to do it. And if he wasn't told, if nobody paid attention to him, or if somebody didn't say anything, he would keep pointing to what he wanted to do. He wouldn't turn around and see if anybody was looking, but he would point to it, but he wouldn't go to it at all unless he had permission. And they noted this at school as well. This has created a lot of problems for the family in many things. So it took forever to eat meals, and he missed the school bus a number of times because they couldn't get him ready in the morning. So he was started on lorazepam 1 milligram twice daily with slight reduction, but in this need for prompting, but there was no functional improvement. So it was still a significant issue. And he was also quite sedated during the day. And so his parents reduced it to 1 milligram at bedtime only. Early this year, he then developed this new sort of repetitive behavior. And again, he had a lot of unusual interests and stereotypies in the past, but not really this kind of repetitive and ritualistic behavior. And so he began to insist upon doors and windows throughout their house being closed, and I think at school also. And if anybody opened them, he would go over and close them immediately. If he couldn't close them, if somebody prevented him from doing that, he became really agitated and would become aggressive and self-injurious. And his mom was saying one day that she was quite worried that if she went outside to do something, that he would close the door behind her because he wanted to close, and that she would be locked out. So she had to make sure that the doors were always unlocked whenever she was at home or going to go out, because she could get locked out of the house. So at school, what also happened more than at home at this point in time was, again, this is sort of March-ish of this year, that as before schools closed down, he began to become much more insistent about things being exactly where he thought they should be. It's not clear that that's where they actually were meant to be, but in his mind, that's apparently where they had to be. And he would spend a lot of time looking around the room, and if anything was out of place, he would sort of jump up and go and move it. And to the point, though, if people were actually holding something or if they were doing something and he thought it wasn't in the right place, he would go over and grab it out of their hands and then put it where it was supposed to be. And his teachers described this behavior as relentless, just a scanning and looking for things. And if he couldn't move things, or if he couldn't put them back to where he wanted, he became quite agitated. And again, it was sort of a flare-up of aggression. Throughout all this time, with the windows and the doors issue, and then this issue of things having to be in the right place, he continued to need permission or prompting to do things. His mom said, perhaps it was a bit better, but then when I talked to her, she thought about it and said, no, it's probably not any better. We've just gotten used to it and we work around it and we give ourselves extra time. So they weren't really dealing with the behavior. They were just giving extra time and making sure there was somebody available to tell him to do, or that it was okay to do things. So So the lorazepam was increased to 2 milligrams at bedtime only, because sort of some of the repetitive behaviors he had and the need for permission and stuff like that would take so long, it would actually keep him up well beyond his bedtime. And then he was late falling asleep. And so and on the next day, this kind of behavior would be even worse. And this sort of continued through the summer this year. He returned to school in September, same school, same people, with little improvement. So these are things that are still pretty impairing. We had talked previously about possible SSRI. His parents, at this point in time anyway, felt that they were managing at home. I guess it's not my place to question that, but it certainly sounded as though it was pretty impairing still. And so they didn't really want to use other medicines. I mean, he was already taking guanfacine and olanzapine, so they felt that they were concerned about giving him too many medicines, understandably. So when I saw, so recently, so his medicine is olanzapine, guanfacine, and then lorazepam at bedtime. And so in terms of his history, he's healthy. He's never had any operations or hospitalizations. There's no seizures. He has no allergies. A microarray did not reveal any copy number variants, and he's never taken any supplements or special diet. So in terms of the family history, there is no consanguinity. His mother's never had any miscarriages. He has 2 older siblings. So his older brother, Chris, has no developmental or psychiatric problems, and in fact does quite well. Another sister, whose name I think is Meg, she also has autism spectrum disorder and intellectual disability. And interestingly, during the summer of 2020, she developed this ritualistic behavior around coming downstairs. And again, this is something that his family as well, obviously, same people, they had never seen before. In fact, that there had never been any ritualistic or repetitive behaviors really with her. And she would, in coming down the stairs, she would start coming down, and then she would have to go up and start over again, presumably because it wasn't right or something like that. Again, she's nonverbal, and she would have to do this over and over again. Now, at the time last summer, because everything was closed and she wasn't in school, it didn't create huge problems, but it did take a long time. It has since then improved on its own, essentially, and is really not a problem now. And there's no other family history of developmental or psychiatric problems. And so the mom said the pregnancy was unremarkable, again, that there was no medications, she denied any substance use, and there were no infections. He was born at 40 weeks by spontaneous vaginal delivery. And his speech milestones were really delayed, and he was diagnosed with a global developmental delay before a diagnosis of autism spectrum disorder. So in terms of his mental status exam, so his height was 135 centimeters, his weight was 30 kilograms, his head circumference was slightly above average, but not dramatically so. He had no dysmorphic features, there were no tics, he didn't have any unusual involuntary movements. So when he came into the interview room at the hospital, he didn't acknowledge me at all. He sort of just went by, and he didn't respond to me calling his name or greeting him. He sat beside his mom and did nothing for quite a while, but then eventually he got up to go and get a toy, but he took a couple of steps and then he sort of stopped and looked backwards, I think in the direction of his mom. He didn't make eye contact with her, but he sort of looked back, and then she said, "It's okay, go ahead." And then he took another couple of steps. And so she had to do this a few times before he was able to get a toy out of the toy bin. He then picked up a toy plate, and once he was sitting down again, he spun it on a table in the room for quite a while. And as he was doing it, as it was spinning, he sort of did the thing that we see some people do, where he'd sort of get up on his toes and lean forward and do this sort of movements behind to the side of his head or behind his head. Throughout the appointment, he didn't use any words. There were no vocalizations at all. And so again, what really struck me about this young man, or this boy, was that the description of that need for permission or prompting to do almost anything. And it's, again, almost identical to the other boy. I was at first wondering if somebody was playing a joke on me or something like that. Any thoughts or comments about this person? Anybody have any comments they would like to make? Claire, your hand is still up, but is that from before? Oh, there we go. Okay, so Dr. Mitchell actually wondered about obsessive compulsive disorder. So in saying that, Claire, which part are you thinking about? Is that with the need for the doors and the windows to be closed, or things being in the right place, or with this sort of need for prompting for things, or all of the above?
Okay, so I'm not sure about the prompting, although I just wonder if that is a desire for perfectionism, but it's more the doors needing to, and windows in a certain way is very persistent. You know, it wasn't there before, now it is. So that's OCD as opposed to some of the repetitive restricted behaviors of autism alone. And the need for things to be in a particular way, like where things are in the house, for example. So I think that's what makes me think about OCD.
Yeah, I mean, certainly that part sounds more potentially like OCD. And again, it's interesting that during all this time, his sister developed similar behaviors with sort of needing to redo things. I just don't know how to explain the prompting. In that, you're right, it might be sort of some kind of perfectionism or need for things to be just right. But it had never been an issue previously.
Yeah, although I'm just sort of scrolling through my mind about that particular behavior and a lot of the kids that come through the Tourette's clinic, they do an awful lot of checking to make sure they get it just right with their parents. Not quite in the way that you've described, but some of the more severe patients are immobile and cannot even speak at that time to describe what's going on. So in someone who's also has an intellectual disability and autism, I think we're just observing that they need the prompting. It's so hard to say exactly what's going on in their head.
Well, you're right. And I think the parents of both these people had gone ahead and started prompting him to do stuff, but one boy because he had lost significant weight, and I think with this boy because otherwise he wouldn't do anything. He would just stand there all day. So that's the concern that they had.
Yeah. I mean, it's so hard when we're observing behaviors that could have a number of causes, right?
Yep. Okay, so, diagnostically, again, we're sort of left, or I was anyway, with this question. So he clearly has autism spectrum disorder, he has an intellectual disability, and again, how do we explain this other behavior? So I'm not going to talk much about the other, the female patient that I saw with a similar thing, but again, I had seen her a number of years ago, diagnosed with autism, and had sort of not seen her for several years, and her mom had contacted me early this year with essentially, again, the exact same story, that she needed prompting to do almost anything, and her behavior analyst that was working with her and her family had noticed a significant deterioration. She had stopped speaking essentially. Now, whether she lost the ability to speak or just wasn't speaking, there's no way for us to know. And she had again had needed this prompting to do things, and it really slowed down and had a significant impact on her ability to function. And what struck me as interesting about these three cases is, again, I don't recall seeing many people with autism anyway with this sort of constellation of symptoms, and the fact that all three of them happened within the same year. Is that a coincidence or is it something more? Dr. Mitchell, you just need to unmute yourself.
Yeah, so as you're talking, I'm just wondering how much prompting were they getting in the classroom setting prior to COVID?
Not much. I mean, having known that the girl in the past, and actually having known that boy and his sister for a while, the second person, minimal, if anything, really. So it wasn't a common thing. With the other boy, because I hadn't seen him for a number of years, I don't know, but the sense I had from his parents was this was a completely new behavior, and it was something that wasn't typical for them. At school, I don't know, but they didn't describe it as something that they thought happened. And with the first boy I talked about, his family was pretty strong at advocating for him, and I think if it had been an issue at school, they would have known about it. That's a hypothesis, but that's the sense I got from them. So let me move on a bit, just to talk about sort of, what kind of thoughts I had about these people. So, how do we explain this? So a minute ago I said, that I've never seen, can't recall anybody with autism that I've seen in the last 20 some odd years with this constellation of difficulties and the acuity that it seems to start with, and the fact that it happened to three people within the same period of time and after the onset of a pandemic. I don't know whether that's a coincidence or not, but I think it might be a bit naive to assume it's got nothing to do with it. At the same time, with the first boy, what his mom said when I asked her, do you think it's just got something to do with because his schedule had changed and there were a lot of differences. He was in school, then he was out of school, then he was in school, and she said, as far as she could tell, that didn't particularly bother him, at least outwardly. And she said, in fact, that his sister was much more upset by it. His oldest sister was his sister, who was next in line with the older of the two girls. He said, she was much more bothered. She was more bothered by it than he had been. So I don't know if stress really explains it, but having whatever that means. At the same time, I think it'd be a bit naive to assume it's got nothing to do with it. So Ben raised the question, Dr. Gober did, about would behavior analysis show how much behavior is attention seeking and how much anxiety reduction? I would think so. The difficulty with the world right now is that because of the coronavirus, for a long time, people weren't able to go out and see people in their homes, and schools were closed. And it's the kind of thing you're not necessarily going to get a good sense of by video, I don't think. And I apologize if I have stepped on anybody's toes by saying that, but I would hope so, but it just wasn't something that was available right now. So a second possibility that occurred to me was it sort of an acute onset of obsessive compulsive disorder? So certainly could be, and with the middle boy, given the need for the windows and the doors to be closed and everything at school had to be in a very specific place, could be. But that really, I don't think, explains necessarily the prompting that we saw or the need for prompting. And it could be also, but I just don't know if we should say that. I don't know if we should necessarily accept that as an explanation, given that we really don't know what drives this behavior. So third possibility, this is what his the middle boy, the first boy, whose primary care physician actually happens to be the primary care physician for the third girl also, but had wondered about catatonia. So in the DSM-5, and I actually completely forgotten about it, under autism now they have a with catatonia specifier, and then they say, you should look at the description on page 119. So if we go there, and this is though the specifier that they have around catatonia is for any mental disorder. So it's not specifically to autism, it's whether it's schizophrenia or bipolar disorder as we think more typically. And a lot of these I'm not sure necessarily apply. So I don't think catalepsy was seen in these kids. There was no waxy flexibility. I don't think there was any negativism or posturing. And certainly no internal agitation and no grimacing or echopraxia. That they, again, I don't know if you can say that somebody who is nonverbal has mutism. And so when they say exclude if known aphasia, I would hope that applies also to people who are nonverbal. These people all had stereotypies, or several of them did, but they existed prior to the onset of this. And so I wouldn't pretend to be an expert in catatonia, but I would think if we're going to count the symptoms towards catatonia, that they should be fairly new onset as opposed to things that have existed previously. And I think at least one of them had echolalia, but again, it predated the onset of these difficulties. So in looking at that, I don't personally think they meet the criteria for catatonia. Claire Mitchell raised, I wonder if they had many prompts built into the structured school problem or the structured school day that were suddenly lost in COVID. And that certainly could be. I don't know how we would know that because the parents, or at least of the one boy, said they didn't think that was the case. But certainly, and so that maybe, when I said it was related to stress related to COVID, maybe, but just more generally, the change in everything due to the pandemic may have been part of it. So as I mentioned, when I look at the catatonia associated with other mental disorder, to me, I'm not sure they meet the criteria. However, there are people who have written separate criteria for catatonia and autism. So Lorna Wing, who is one of the, she would be on the Mount Rushmore of autism experts, I think. She had written a paper back in 2000 in the British Journal of Psychiatry, and has written some other things since then about catatonia. And she published this one paper, and she set out these criteria. The difficulty is that they call it catatonia, and I'm not sure that's the right term, because if it is not necessarily the same as catatonia that we see in people with bipolar disorder or schizophrenia, I think that perhaps a different term should be used. But anyway, so she described these sort of 4 essential criteria. So increased slowness affecting movements and verbal responses, perhaps. Difficulty in initiating and completing actions, sure. Increased reliance on physical or verbal prompting by others, yep. And increased passivity and apparent lack of motivation. So with these 3 people, their parents said that they often looked like they wanted to do something, they just needed prompting to do it. So I don't know if there was really passivity or the apparent lack of motivation. And I don't know if there was slowness affecting movements and verbal responses as opposed to not doing it. And I don't know how you would distinguish the increased slowness from difficulty in initiating and completing actions. And then she also talked about sort of minor criteria, which would be things like reversal of day and night, which didn't happen, Parkinsonian features, which we didn't see, excitement and agitation, for a couple of people, for the one boy only in the context of frustration, I think, and then an increase in repetitive and ritualistic behavior. So certainly for one boy, but I'm not sure that overall that they would meet the criteria as outlined. And these were, I think, her recommendations or suggestions around what we should call catatonia and autism, that there's been some research on them. And interestingly, she reported in this one paper that out of about 500 people with autism that they saw in England in one clinic, that she reported that 17% of them met the criteria for what she described as catatonia. It seems like an awfully high number to me. But she also said that nobody under 15 had these kinds of difficulties. So the other thing that I had wondered about really was, again, this repetitive behavior as part of ASD. So was it that when we look at the criteria, it's inflexible adherence to routines or ritualized patterns of verbal or nonverbal behavior? So was it that for some reason a ritual had developed where people couldn't do things unless they were told it was okay to do that? Now, I don't know why that would start. And I suppose there's a lot of assumptions in saying that perhaps it's related to the ritualistic kind of behavior, or the insistence on sameness, or the inflexible adherence to routines. But it's certainly something that I've thought quite a bit about. And outside of the catatonia, to me, this is perhaps the most likely explanation. At the same time, I don't know why it started now. I don't know why it presented the way it did either, given, again, I don't think I've seen anybody with this kind of presentation in the past, or at least I haven't recognized it. And the other part of that is, at least with the one boy with the fluoxetine, things seem to get better. Now, that may have been a coincidence, but in general, we don't think of SSRIs as being all that helpful for ritualistic behavior in people with autism, so I'm not sure. So at the end of the day, I'm left not really personally knowing what's going on with these people, and so I'd like other people's opinions, if they have it, that certainly one boy has gotten better with fluoxetine. Whether that's coincidence or not, I don't know. And return to school. The second boy, really, it hasn't changed much, but his parents haven't, at this point, aren't particularly interested in trying a different medicine. And with the third, the girl, who I didn't really talk much about, so she, I think, takes a pretty whacking dose of lorazepam. I think she's taken 5 or 6 milligrams a day, and she's 7 or 8 years old. And her mother has said recently, she's making slow and steady gains, but again, over a period of 8 or 9 months, I don't know whether that would have happened anyway, and whether or not whether the lorazepam actually made a difference, or is it just sort of along for the ride? So, that's all I had really wanted to present, and it's a bit of a conundrum to me, but also interesting in the fact that I haven't seen this before, at least interesting to me, and I don't know how to explain it. So I would like to open the floor if anybody has any comments about that. I will look at the chat here. Dr. St. Pierre, lovely for you to join us. So what Dr. St. Pierre said, and Jeff runs a selective mutism clinic here at CPRI. Said, I've only had one client I can recall in the past 30 years referred to me for selective mutism who was completely frozen and prompt dependent in the classroom. And Jeff, was there anything else unusual about that person other than that? So the fact it was an unusual presentation? Was there anything else about his diagnosis that was unusual? So I will wait for Dr. St. Pierre hopefully to respond to that. But so Dr. Goldberg also had asked, would functional brain imaging assist in differentiation? I don't think so, Ben. And again, I wouldn't pretend to be an expert in brain imaging, but I don't think it helps. I don't think the technology is there to be able to distinguish individuals for the most part. I think in research studies and in looking at group averages, I think we can see differences between different diagnostic groups, but they're not always found reliably. There's not always replication, and I don't think it would apply to individuals necessarily, so I don't think so. I think the other reality is for most functional imaging, people have to be awake while they're in a scanner, and I think for these 3 people, that would be remarkably difficult, if not impossible to do. So, and Dr. St. Pierre was just talking about, I just replied about the other person I had asked about with, who had sort of been prompt dependent in the classroom with selective mutism, and Dr. St. Pierre just said now that he wondered about whether there had been some waxy flexibility based upon my sort of mentioning the possibility of catatonia, but it sounds as though he's not completely sure about that. So, Monique, if you're still here, one of these people, the one in the middle, is a family who lives slightly south of London, who you've been involved with. If you know who I'm talking about, I just wonder if you have any thoughts about that young man, that boy. So hopefully Monique is still here, but while we're waiting, so Dr. Mitchell had a comment or question. Go ahead there, Claire. Because it said, Claire, that there were, oh, sorry, yep.
Oh,
Claire?
I forgot to put my hand down. I mean, I think I've made my comments. I still think, you know, comorbid OCD kind of fits with the sort of relatively acute onset. And my question, I guess, is, did Lauren Wingfield mention the duration? Like, did once people developed this so-called catatonia, did it persist? Because I need to look up that previous patient and see how much prompting he required, because it really was there for 2 or 3 years and then resolved, which also kind of fits with the waxing and waning natural history of OCD.
But I don't know if we'd expect OCD to completely resolve, though, either. Over time. But so, to be honest with you, as you may know, I am one of the world's best procrastinators, and so I was reading Lorna Wing's paper at about 3:30 this morning, so I have no idea. I think she does talk about duration. I just, off the top of my head, I can't recall what she said about it. I will look it up and get back to you. Were there other comments or questions or thoughts? Criticisms, concerns? Dr. St. Pierre, you just have to unmute yourself.
Hi, Rob. Thank you. I am thinking about a film that we show in our exposure response prevention group for OCD to our clients in the break shop. And it's a client who spends all day long asking his parents' permission. He can't do anything, can't get out the door, can't do anything, and keeps asking, is it okay? Is it okay? Is it okay I do this, Bob? Is it okay I do this? And of course, she's lost her mind with needing to offer that reassurance every single thing, and he never does anything. And I do wonder about a nonverbal OCD where you had that same urge, but you didn't voice it as a need for reassurance in the way that that boy did. But his day was frozen by repeatedly asking for reassurance. So if you equated that to a nonverbal child, it would essentially look the same, I would think.
Absolutely, you know, and I think that's a really excellent point. I think that's what Dr. Mitchell was saying. I guess for myself, the only reason I've perhaps not been more, I don't know if accepting is the right word, but it's just, you know, to not really have seen anybody with autism like that in the last 20 years and have 3 people within the space of 6 or 7 months. And again, I mean, coincidences happen, we know that, but it just seems unusual. But certainly, you know, I think there are a limited number of possible explanations. And I think that anxiety perhaps makes sense at some level. And certainly OCD, it could be. I mean, that makes sense. And so Dr. Kelly had wondered about any increased irritability. I don't think so. That the one boy, in fact, really, the middle person I talked about, he had a history of significant aggression and self-injurious behavior. It is better now than it was in past years, but still, if he's told no or has to wait for something or can't do something, he still can become quite aggressive or self-injurious, sort of like when if he was stopped from closing the windows or the doors. But I don't know if we would call that increased over his baseline. I think it's just another time when he would do those kind of things. Okay, well, if anybody else has any comments or thoughts, I really appreciate them, because you know, I'm other than the one boy with the flux, I'm not sure where else to go with these people. And again, I think it's just been fascinating for me to watch them. So Julio, if I may, and I don't want to put you on the spot, but I'm going to anyway. So the title of the talk, the Ritual de lo Habitual, is that even close to the way that should be phrased, or is that close to the right pronunciation? And I saw your hand up a second ago there, Julio, and now I've lost it. But if you want to talk, feel free to go. Oh, there you are. Yep, you just have to unmute yourself. I think.
Oh, I cannot mute myself.
Yeah,
I think that this is perfect. Ritual de lo habitual. Yeah, that's perfect in Spanish.
And so I think, Julio, because I know I had asked you about this, but I think it actually means ritual of the habitual, or of the usual, I guess.
That's correct. So I think that rituals are a ritual is what you do. I think ritual means a higher level of intensity than habitual, than usual, which is pretty much the same in English. A ritual goes into something that you have to do. Habitual.
But in some ways, I think that these three people, I mean, they really, out of things that were typical or sort of part of their general routines, have now become rituals. So they have developed a ritual from their habitual behaviors, I think. And if anybody is interested, so Ritual de lo Habitual was the name of the second album, I think, by Jane's Addiction. And I was reading something about it. I thought it was a fantastic title for a talk. So that's where it came from. Although I don't know if anybody's interested other than myself. Julio, was there anything else that you had wanted to comment upon?
No. I was just saying that a ritual, if you don't do it, produces anxiety and things like that going to the pathological. But it's perfect for me. I mean, the comment that I had on when you asked me at the first time is because there are things that there are habits that you kind of skip and they don't necessarily cause stress or anxiety. But, you know, the rituals, they do when you skip them. I think that that's the way that I saw it, the interpretation. I think that is a great title because sometimes it's different it's hard to make a difference between these two things. Yeah.
Yep, absolutely. Thank you, Julio. So just to finish up. So first of all, I think, and correct me if I'm wrong, Sarah, that you will be sending out a link for people to complete an evaluation, and then when that's done, they will get their CME credits or CPD credits. Is that correct? Oh, sorry.
Yeah,
So
I send the certificates and the link for the evaluation together. It's not a prerequisite to get your certificate, but you have to fill out the evaluation.
No, people have to fill it out with only 7s or whatever the highest mark is in order to get their credits, I think is what we're going to say from now on. Okay, so you'll be emailing everybody who attended?
Yes.
So next month, on November the 10th, Maha Saleh from the Department of Genetics is going to talk about sort of an updated overview of genetic testing in people with developmental disabilities. And in particular, she was saying recently that there are some new data to suggest that we should be doing exome sequencing sooner because the diagnostic yield has been higher than what some people might have expected. The other thing I wanted to point out was that on October 27th, Dr. Mitchell is hosting the second annual London and Region Fetal Alcohol Spectrum Disorder Conference with some excellent speakers. So if people are interested and haven't seen the announcements, you can go to the dual diagnosis program or developmental disability program, sorry, website at ddp.uwo.ca, and in the research area, there's information and a link to that. Claire, is there a charge for that? Oh, so Sarah said, yes, there is, but it's not too much, or it's not much. So, and that's it. So thank you everybody for attending. It's been really helpful for me just in thinking about patients. I hope it was of interest to everybody else. And we will see you all on October 27th and then on November 10th. Thank you.